Good afternoon, everyone. My name is Dr. Peter Eke, and I have the pleasure of introducing our president who's going to be giving his presidential address. So Dr. Ashraf Mansour is latest president of the Midwest Surgical Association. So he was born in a land far away in the ancient land of the pharaohs and pyramids. And with all he has accomplished, I'm certain that if he would have been a pharaoh if he were born in that time. His parents were Ibrahim and Laila Mansour. His father was a general surgeon, so the apple didn't fall far from a tree. And his mother was an educator. Also, he has a prominent role as a teacher. Those are some of his pictures when he was a kid and growing up. That's his grandmother. He had an exciting childhood growing up in Cairo and graduated from one of the most prestigious schools in the Middle East and the African continent. That's the Cairo University School of Medicine. And then started his journey to the United States and came to the United States in the 80s to pursue a surgical career and completed his residency at the University of Colorado, Denver, under Alden Harkin, who's pictured there. He started there as faculty and in the Denver VA. There was no 80-hour work week back then, so that was after probably a rough night of call. He had a short stint in the U.S. Army as a captain. He was at Fort Benning and went on to do a vascular fellowship at Southern Illinois University and was at Loyola University briefly until he ended up at his current position at Spectrum Health, where he's currently the academic chair of surgery. He's married to Gina Warren, who is here in the audience. I have two daughters who unfortunately could not make it here. He is a family man, obviously loves to do a lot of things with his family, as pictured there. Also loves to have fun both in the sand and in the snow, as pictured over there, although things didn't seem to go very well right there. So he is currently the chair of the American Board of Surgery. So you need to be nice to him if you want your maintenance of certification. He's also board certified in surgery, in surgical critical care, and vascular surgery. And he's also, interestingly, the past president of the Western Surgical Association and also of the Midwestern Surgical Vascular Society. So after seeing all these great accomplishments and storied life of Dr. Mansour, I tried to dig out some dirt on him by talking to some of his colleagues, residents, students. And after doing all that, this is what I found. Nothing. So I just had to accept that. I went to ChatGPT and I still got more stuff, which said more good things about Dr. Mansour, mentor to And I just had to give up and accept that he is a gentleman, scholar, husband, father, mentor, leader, a veteran, a trailblazer, a fun lover. And I'm glad to present to you our president, Dr. Ashraf Mansur.
Dr. Eki, that was very nice of you. I don't know if I deserve this. Just gonna take a second here to absorb the view and everybody. Thank you for staying. It's been a great year, and I'm really honored to be here. So, ladies and gentlemen, members and guests, it is indeed a great honor to stand before you as the president of the Midwest Surgical Association for the last year. I first came to this meeting in 1996. Dr. Steve DeYoung actually encouraged me to come, and I was introduced to many of you and became friends over time and looked forward to our yearly assembly. So every surgical society has its own characteristic features and traditions. And as you know, the Midwest Surgical Association was started in 1958 by Midwestern surgeons who felt that they could fill some void and offer something that other surgical societies couldn't necessarily provide. I don't have any disclosures, I forgot to put that up. I'm a rat pack, or pack rat, and here are some of the books of our annual meetings that I sort of collected over the years. So our association here focuses on the advancement of the science of surgery in a relaxing environment with free time to pursue sports and outdoor activities and many opportunities for conviviality. As a new member, I remember participating in tennis tournaments, the annual 5K run, and the golf outing that many of you do as well. There's no question in my mind that members and their families keep coming because they enjoy what the association has to offer, not just for the science, but also for the social program. Our Midwest Surgical Association has strong Midwestern values characterized by a warm and welcoming attitude, respectful, accepting of other cultures and backgrounds, and embracing diversity with the inclusion of both academic and surgeons in private practice. This is really important to emphasize because the atmosphere we live in currently, in my opinion, has become more contentious and perhaps a touch xenophobic. We read about the Great Divide or the polarization of people, but the saddest thing is the emerging characteristic of incivility, of entitlement, of refusing to hear the views and arguments of other people. This tribalism can only lead to the destruction of the fabric of our society and the breakdown of all the great values that set our country and culture apart from any other place in the world. Everyone knows that in America, if you work hard, you can achieve great things. While there are still barriers for some of us that we need to overcome, we have made some progress and need to continue to do better. Americans, and especially Midwesterners, have always been known to be generous and welcoming people, thoughtful, willing to listen, and above all, fair. This is what drew me to come here, and I made this my home, and I'm sure that many others have similar feelings. When I came to the United States, I first landed in Michigan as an immigrant. And even though I have moved around for the last 40 years or more, I've made the Midwest my home, having lived in Illinois for 9 years and in Michigan for 24, more than half of my life. So Socrates said, the unexamined life is not worth living. I've had the opportunity to reflect on the last few years of my life and career. There's no question that in our life journey, there's an element of luck, or call it serendipity. And for reasons outside of our control, conditions become favorable for certain actions that later, in retrospect, are deemed fortuitous. As a medical student, I came to the University of Colorado and rotated twice in my senior year. I fell in love with the surgery program there and later applied for my residency. I feel very fortunate that I was selected to be a resident there and was able to complete my training. As you heard, following my residency, I served in the United States Army Medical Corps as a general surgeon. Then I did my vascular surgery fellowship at Southern Illinois University, my first real job out of fellowship was at Loyola, and I was fortunate to have great colleagues, friends, and who supported me professionally and encouraged me to become a member of this association and other societies. These are some pictures of some of my attendings and mentors at the University of Colorado. Some of you may know Dr. Ben Eisman. You've heard of Dr. Alden Harkin, of course, Gene Moore, and Dr. Al Hopman were all great role models for me and mentors. Our surgical world is fairly tight-knit. It seems like the idea of a 6th degree of separation holds true in our surgery world. First introduced to another surgeon, even if you don't recognize their name, you feel like you know a colleague of theirs from medical school, residency, or somewhere along the arc of their career. When I started out at the University of Colorado as a surgery resident, Dr. Alden Harkin had just been appointed as chair of surgery, and at that time was one of the youngest surgical chairs. He had been professor of surgery at the University of Pennsylvania and came to Denver to assume his new job. The previous chair was Dr. Tom Starzl. Shown here as his memoir is The Puzzle People and a picture of Dr. Starzl. He pioneered many of the techniques of liver transplantation during his tenure as chair at the University of Colorado. Dr. Harkin, he took personal interest in the residents and fellows trained with him. He was generous with his time and advice. He always wanted us to do better, not just surgeons, but as human beings. He taught us how to read and interpret the surgical literature critically. He instituted the surgical debates, you see the books here, a weekly session that was held every Saturday morning before surgery grand rounds, where residents would be assigned a topic randomly that they would have to defend, like splenectomy versus splenography for trauma. Ultimately, these debates were published in these textbooks, and they were quite popular at the time. The vascular chief at the University of Colorado was Dr. Bob Rutherford. He sent me this picture. It was a Christmas card, I think, in 1998. But he was the first editor of the book Vascular Surgery, which is considered the source of information for our specialty. Dr. Rutherford gave me important career advice and supported me by writing me strong letters of recommendation. Later on, when he became the editor of the Journal of Vascular Surgery, he invited me to review papers in the journal and helped me contribute to the science and literature of vascular surgery. Another mentor, Gene Moore. Some of you in trauma might know him. He was a surgeon and researcher. He is continually funded by the NIH for 30 years. Ken Maddox and Dave Feliciano, he also edited this book, Trauma, which is also the main source of information for trauma surgery. In my fellowship, I trained with Dr. David Sumner, another icon in vascular surgery and one of the early adopters of ultrasound in vascular surgery, who worked with Gene Strandness at the University of Washington. I was recruited from my fellowship to go to Loyola and help start an endovascular program by Dr. Bill Baker. Dr. Bill Baker was a previous president of the Midwestern Surgical Association. He's also the president of many august societies, including the Society for Vascular Surgery, the Central Surgical, and the Midwestern Vascular Surgery. The surgeons I just mentioned had incredible achievements in surgery, not just as great clinicians, but also researchers, textbook and journal editors, leaders of surgical societies, and great, great, great role models, not just for me, but for many who were fortunate to train with them. As Sir Isaac Newton said, it is by standing on the shoulder of giants that I have been able to see farther. He was referencing physicists that had preceded him. What I thought I'd do this morning or this afternoon, is to examine our world of surgery and healthcare and do a mini SWOT analysis on where we stand today. We learned about SWOT analysis from business people who use this method when they examine their position in the business world and try to come up with strategies to stay competitive and relevant. The strengths of surgery are numerous. I cannot possibly cover everything today. Suffice it to say that surgery today is safer than it has ever been. We have come a long way from the days of barber surgeons who became skilled in performing amputations and removing bad humors by bleeding patients. We have been able to take care of complex surgical conditions and with skill and ingenuity have been able to perform procedures and save lives, cure some cancers, and at the very least palliate and repair has been broken or damaged by disease or trauma. Just a couple of examples to cite that are familiar to everyone here: I picked pancreatic malignancy and aortic aneurysms. This is a paper written by Dr. John Cameron about pancreatic duodenectomies a few years ago. When I was a resident, the results of the Whipple procedure were slowly getting better, but the mortality rate after the operation was in the 10 to 15% range. Today, in most large medical centers, the mortality rate from Whipple procedures is usually 3% or less. Since laparoscopic and robotic surgical techniques have been refined, surgeons have been pushing the envelope to do laparoscopic Whipple procedures. Of course, it isn't just the surgery, but also the neoadjuvant therapy, and the clinical results have been amazing. The same can be said for aortic aneurysm surgery. When I was a resident, you could safely perform open aortic surgery electively, but the mortality rate was around 5 to 6%. And the mortality of ruptured aneurysms was anywhere between 50 and 90%. However, with the introduction of endovascular techniques in the early 1990s and the manufacture of stent grafts, aortic aneurysm surgery has become a lot safer, with mortality rates in most medical centers expected to be less than 2%. Even with ruptured aortic aneurysms, the mortality has been driven down to less than 20%. As I mentioned earlier, surgery is safe and you can expect excellent results, even for the most complex and intricate operations. So what are the weaknesses in our world? An objective person could come up with a long list of things that irk us or hurt us. We'll focus on a couple of major issues. First, our reimbursement system, which I'm sure any reasonable person will declare it to be broken. The surgeon's fees today are calculated based on a complex and sometimes archaic system that relies on surveys to determine how much effort the surgeon expends in the preoperative evaluation, in the operation, and the postoperative care, not only during hospitalization for the problem itself, but during the first 90 days after surgery. An example, a carotid endarterectomy today is calculated to be worth 21 RVU. Depending on where you live geographically, the RVUs are somewhere between $38 and $50. So roughly $1,000 for a carotid endarterectomy. In years past, as you can see from this example, in 1975, a vascular surgeon could charge $660, which was essentially what they called at the time the usual and customary. And $660 in 1975 is worth $3,590 today. So we're basically, as vascular surgeons, paid a quarter of what we should be paid if the system remains stable. So CMS has been tweaking physician fee schedule, and in a sometimes misguided attempt to move things out of the hospital and into the outpatient arena, such as the ambulatory surgical center or the office-based lab, which is called the OBL. The payment system has been modified to incent this migration of procedures out of the hospital and into the outpatient arena. This example of radiofrequency ablation for incompetent veins is an example of a procedure that used to be paid for equally, whether it was done in the hospital or the outpatient arena. Things, however, have changed so that if a surgeon performed this procedure in the hospital, or I'm sorry, in the ambulatory center, they would essentially get paid up to 10 times more than if they did it in the hospital. So the increase in the physician fees obviously incentivizes people to do this in the ambulatory setting. So based on this rationale, every time things were done in the outpatient setting, the physician's remuneration came up significantly. Unscrupulous practitioners have used this system, and they have essentially figured out that they could enrich themselves by billing for certain procedures, whether it's indicated or not in the outpatient arena. This ease of doing these procedures in the ambulatory settings with minimal capital investment has encouraged many practitioners, not just surgeons, but internists, dermatologists, radiologists, and so on, to enter this ostensibly lucrative arena. In many metropolitan areas, medical spas have sprouted up, appealing to one's vanity, claiming to eliminate wrinkles with Botox or make your legs look gorgeous again with laser treatments. And you can see from the slide here that the projected increase in medical spas is 13.8% by the year 2030. Endovascular procedures for peripheral artery disease. You've already heard a little bit from Dr. Alabi yesterday about this. Endovascular procedures for peripheral artery disease has exploded in the United States. To the lay person, it's not hard to see that a minimally invasive option is the way to go, even if the results were less durable. The tragic thing is when some of these endovascular procedures go awry, from distal embolization or vessel occlusion or dissection or thrombosis, you have now converted a stable limb with claudication to a threatened limb. Indeed, these complications have been reported and lead to emergent hospitalization and expose the patient to the risk of an amputation. The latest scandal in our area is the publication of a front page article in the New York Times, this is it, on July 15th, about some practitioners who have used unsavory methods to lure patients to their practice under the guise of preventing an impending amputation. I don't know if any of you have seen this article, but they basically, those of us who live in Michigan, the practitioners they discussed in the article were in Lansing and in Grand Rapids. They submit their patients to repetitive and unnecessary endovascular procedures, opening up occluded popliteal and tibial vessels with questionable indications. In the process of performing these procedures, they overuse devices, notably atherectomy, because it reimburses very well in the OBL. There have been many articles in peer-reviewed journals documenting the rise in the number of atherectomies being performed in these venues. And several researchers have shown the lack of benefit from their use. The New York Times exposed this and published a story of patients that have been harmed by this practice, getting an amputation when perhaps they didn't need anything in the first place. In a recent audit from a major insurance company in Michigan, some of the highest billing practitioners were using every single tool they had in their toolbox. They were using balloons, stents, intravascular ultrasound, laser, atherectomy on almost every patient, whether indicated or not, to maximize reimbursement. Unfortunately, some of the most egregious examples of unethical, I call it criminal, physician behavior have found allies in industry. We've seen the proliferation of industry-supported workshops and symposia focusing on teaching physicians, quote unquote, new techniques and encouraging them to use devices that haven't yet proven to be beneficial. I ask you, what is the difference between them and snake oil salesmen? This is an example that I wanted to show you. The blue bars is what you would get paid for an atherectomy if you did that in the hospital. And the orange bars is what you paid for an atherectomy if you did it in an outpatient facility. So if you do an atherectomy, you get paid essentially about $12,000. That's physician fees, $12,000 to do this in outpatient facilities. So the modus operandi is to dupe patients into thinking that they're about to lose a leg if they don't submit to evaluation and treatment by these fly-by-night outfits. The patients are then put through an assembly line of repetitive procedures to intervene on stenosed or occluded vessels with minimal or no indications. This is an example of advertising in a vascular center in the South somewhere, where they scare patients into coming in to see them. Then the patients are brainwashed and led to believe that they just avoided a disaster or an amputation, and that the physician is falsely praised as a hero and a savior. Some have gone as far as telling referring physicians and podiatrists in our area and others that their patients should never be submitted to amputation before these self-appointed experts are able to weigh in. The New York Times article highlighted that some of these practitioners were the highest billers in Medicare nationally. A couple of years ago, a practitioner in Florida billed CMS for $18 million in 1 year doing peripheral interventions. It is mathematically impossible to make $2 million every year performing procedures legally. As a practitioner is performing this, doing concurrent surgery, which in itself has questionable practice, it is impossible to rack up the necessary RVUs to get to that level. Therefore, we must conclude that reaching these stratospheric levels of remuneration can only be achieved by fraud and abuse. I'm sure many of you have to sit through an educational session about fraud and abuse that all health systems are required to offer to physicians on an annual basis. This is an example of fraud and abuse performing unnecessary procedures on healthy patients for taking indications, and instead of saving limbs, resulting in complications that lead to amputations. It is estimated that approximately 10% of our healthcare dollars are wasted in fraud and abuse. This is a pattern that has also been seen elsewhere. Congress authorized the American Rescue Plan Act and the CARES Act, a total of $4.6 trillion to support businesses during COVID pandemic. To put this in perspective, we spend $4.3 trillion on healthcare every year. It is estimated 10% of that as well, if not more, was obtained fraudulently, and worse, much of this money may never ever be recovered. As a profession, it seems that we have failed to police ourselves. Perhaps as a result of government regulation or other factors in our healthcare system, the independent private practice is essentially driven out of business. When you look at the landscape in the United States today, 3 out of 4 doctors are employed. That means the business of medicine is being run by large corporations. Well, this be a necessary step in our evolution. I think that it's not a positive change. In fact, when physicians are employed, they have to give up their autonomy, and the reporting structure is such that more and more administrators run the practice and make clinical decisions for you, frequently based only on a financial basis or on profits and losses, as opposed to what's best for the patient. Recently, Dr. Berwick, who's a clear thinker and a leader in healthcare policy, decried the greed displayed notoriously by big pharma and industry and warn this has seeped into other healthcare corporations and hospital systems. These large entities are known to reward CEOs astronomical salaries. In fact, when you look at the quadruple aim, as a country, we have failed to improve population health significantly. We have not made significant progress in reducing the cost of care. When you compare us to other industrialized countries, we still spend significantly more per capita on healthcare. And yet, our outcomes aren't necessarily better. The orange bar is the average for all countries in the world, and the very left bar, blue, is the United States. And above all, I think we have failed in improving provider satisfaction. These are all graphs showing that we're lagging in terms of doing that. In fact, the rates of depression, substance abuse, and suicide among physicians has only gone up. One of the most impactful talks I've ever heard was the AAS president, was the AAS presidential talk given by Carrie Lubitz, who is a Massachusetts General Hospital surgical endocrinologist, and she gave her talk in February at the American Surgical Congress. Has anybody seen this? It's one of the most impactful talks. If you don't have the link, please email me. I'll send it to you. She discussed her personal mental health struggles in the last year. Very, very impactful. Furthermore, physicians are reported to be engaged in non-patient care activities in up to 38% of their daily activities. This graph shows you different specialties, and surgery is right in the middle of the pack. Some of these activities are administrative activities or spending time in the electronic health record, obtaining pre-approvals for procedures for their patients. New terms have been coined, like pajama time, to describe time spent on the electronic health record to prepare charts or answer messages or look at test results on night and weekends when the physician is not on duty. It is alarming that many physicians, when asked if they would recommend the medical career to their kids, they responded they wouldn't. So what opportunities do we have? Rahm Emanuel, who was Barack Obama's chief of staff, said, "Never let a crisis go to waste." I'd admit that I painted a picture, a somewhat bleak picture of our state of affairs. I think we have some way out. First of all, I want to tell you that in our society, physicians and surgeons are among the most trusted, most revered, and most respected professions. It always amazes me that on a weekly basis, I have a patient in my office for the first time, sent or referred by their primary care physician to have an aortic aneurysm evaluated. I meet the patient, and sometimes their families are there, and we review the imaging, and we begin to talk about what the problem is and what needs to be done. We do a risk assessment, and we see if the patient is a candidate for repair, and then we recommend surgery to fix the problem. The patient has never met me before, yet they don't have any hesitation trusting me with their life to fix the problem. All of you experience this in your clinic on a daily basis. I ask you, what other profession has this privilege? Not judges, not lawyers, not politicians, not even the clergy. The patient is comfortable telling you all about their problems. They entrust you with their lives to make surgery, to take them to surgery to perform an invasive procedure that they understand that they could die in the process. And yet they're willing to risk that because they trust you, and they're saying, and they're willing to follow your recommendations. This is an incredible privilege if you think about it. And in order for us to continue to earn this trust, we must continue to advocate for our patients. We have to do everything in our power to ensure that they have a positive outcome. We have to be physicians, which means, in my view, that you also have to put the patient first. We must go back to teaching the look, listen, and feel, and actually touch the patient. There's a TED Talk that was given by this author here. I don't know if you, it's the third one from the left, Abraham Verghese, who's a physician, author, and infectious disease specialist. In his TED Talk, he describes making runs on a patient who's dying of AIDS. When he approaches the patient's bed, the patient is ready for the patient, and he unbuttons his gown so that the doctor can listen to his chest. The patient knows he's dying, and yet he's looking forward to the physician touching and examining him. Ladies and gentlemen, this is what it's all about. This is what keeps us going. This is what makes surgeons so special. We have got to teach our residents and fellows that making rounds is not sitting at a table to discuss the patient's labs and vital signs displayed on the EHR. It used to infuriate me that when I was covering the surgical intensive care unit, I would see the residents sit outside the room to write their notes, just looking at the computer. Nobody ever looks at the patient. Nobody would walk in, actually examine the patient, look under the sheets, feel the patient's abdomen, and look at the patient's feet. In the age of artificial intelligence and electronic health records, I still believe that the physician's warmth and personal touch are not only maybe essential in taking care and healing our patients. We must continue to teach this and emphasize that's the most important part of your daily job. The other thing we must do is to participate in advocacy. The other thing we must do is to participate in advocacy. I'm proud to serve on the Committee on Trauma of the American College of Surgeons and to serve in the advocacy pillar. You see me here on one of the visits in Washington, D.C. with our Senator Debbie Stabenow, with some other surgeons from the state. And here it was our other Senator Gary Peters with some other surgeons from Michigan. Our job is to help the American College, and by extension, all doctors, all surgeons, reach out to politicians and explain to them what legislation is needed to take care of patients. Our recent campaign of trying to spread the word of the Stop the Bleed is an example of the things we do to inform politicians on what is needed. Every year, the college convenes an advocacy conference in April, and surgeons are invited to go. And this is your chance to meet face-to-face with your representatives and lobby for your own causes. If you've never done that, you should consider it. You cannot sit idly and assume that somebody else is going to do this work for us. Gun violence has escalated out of control in this country, more than any other country in the world. Perhaps one could say that this is happening far away from us. No, it's not. It's happening right in your backyard. We had a mass shooting at Michigan State University just a couple months ago. Most recently, a hand surgeon, this was just a couple weeks ago. Most recently, a surgeon in Memphis was shot in his office. Many of us are gun owners, and that's okay. What is not acceptable is the complacency many tend to feel about gun violence in our schools, places of worship, and even in hospitals and doctors' offices. Every one of us has a responsibility to speak up, advocate for our patients' safety and our safety. We have a great opportunity here. Finally, threats. I think that the two biggest outside threats that I see are government regulation and private equity venturing into medicine. The example I cited earlier about fraud and abuse, performing unnecessary procedures will be a good excuse for government and payers to make it even more difficult for us to practice medicine. We've already seen the early signs of this when you order a CT scan or an MRI on a patient, and you have to do a peer-to-peer discussion with a physician or somebody to get the insurance covered, the tests covered. This trend is going to continue. In the last year, more than any other year in my previous years of practicing, I've had to deal with getting appropriate approval to perform a procedure or to get a test. When private equity purchases a medical group or practice, the sole purpose of the corporation is to make money for its shareholders. Therefore, the business becomes all about practice efficiency, cutting out the fat, and generating revenue. When we are under constant pressure to make money, our focus is off the patient and something is lost. Perhaps you feel like you don't have enough time to spend with your patients. Perhaps your judgment is slightly clouded because somebody is looking over your shoulder and they're telling you that you're not working hard enough or efficient enough. Ladies and gentlemen, our profession is a noble profession. All of us work more hours than the average American. Not only that, we worry about our patients' being and anguish over outcomes. We must remember that we also have to take care of ourselves. Recently, I was made aware of a very successful lawyer who was admitted to a big medical center in New York City. He had an acute myocardial infarction and presented in cardiogenic shock. The patient eventually underwent cardiac catheterization and coronary stents were placed. And after the procedure, the patient, having stared death in the face, said that the one thing he regrets the most was that he didn't spend enough time with his wife and his children. He had been focused on his job and reputation. He was after making money. His family and his children came second. Please do not make this mistake. As they say, take care of yourselves and each other. So to quickly summarize, we need to do 4 things. We need to get back to being the best doctors we can be. Not tolerate fraud and abuse from anyone, especially colleagues or other physicians. Get involved in the business of medicine and politics, and speak up and advocate, and take care of yourself and your loved ones. Coming to the end here, I'm incredibly grateful for this wonderful opportunity to serve as the president of this association for the last year. There are many individuals I have to thank for their help and support. I'm incredibly lucky to be married to a lovely woman who supports me throughout the year and listens to me when I complain about my day and my troubles. I'm grateful for our children in their own way, encouraging and support and make this worthwhile. I thank my partners who've worked very hard to take care of patients and make me successful. I thank the Executive Council of the Midwest Surgical Association. They work hard to keep our association viable, and they try to make our meetings attractive and desirable for all members. The day-to-day business of the MSA is run by Bill and Margie. I used to them having fun there last night. Both work behind the scenes to make the trains run on time and make sure that we find a nice venue for our successful meeting. Finally, I'm incredibly grateful for the opportunity for being welcomed in the American family and the House of Surgery, and being trusted to participate in various leadership positions in this and other organizations. It has been an incredible honor and an incredible journey, and I want to thank you for your attention and wish you the best.
Thank you very much, Dr. Mansour, for that incredible lecture. And there's a plaque here which states to the Midwest Surgical Association honors Ashraf Mansour MD, upon completion of his term as president, August 2023, with appreciation for dedicated service to the association and exemplary demonstration of the highest standards of surgical practice.
Our business meeting starts in a few seconds, few minutes. Thanks for your attendance.